Thank you. Good afternoon. Good morning, Naga Chalasani. In Indiana, it's my pleasure to introduce our speaker today, Naga Chalasani, who is David Kropp, Professor of Gastroenterology and Hepatology, Professor of Medicine, Adjunct Professor of Anatomy, Cell Biology and Physiology at the University of Indiana, and also Vice President for Academic Affairs, also at Indiana University Health. But mostly he's a top international leader in three topics, really. He's an international leader in alcoholic liver disease, but also in muscle metabolically dysfunction-associated steatotic liver disease, and also in drug-induced liver injury. So he's a very authoritative person in all these fields, but today he's going to address the topic of drug-induced liver injury in patients with underlying liver disease. Thank you very much again for joining. Go ahead, please.
Thank you, Raul. Truly, I'm an honor to speak to this audience. You know, you're experts in this, and I see Fernando in the audience, and I've briefly chatted with Ann Daly. Some of you are really highly respected, and hello, Maribel. Good afternoon. So truly privileged. I would say some of you have heard this talk before, so if you mute yourself and do other things, I won't be offended. But you know, my journey into this space started in, I would say, in 2000, 2001. I was a young faculty seeing patients with liver disease, and we were getting asked mostly about statins. You know, patients have dyslipidemia, they need statins, but their ALT is high. You know, at the time, the package inserts, the label said not to give statins if patients had active liver disease. So that's sort of where my journey really in Delhi started. I started to see if patients with underlying liver disease are at a higher risk for statins, and then came along the Drug-Induced Liver Injury Network. I was privileged to have been selected to be part of it, and some of the work that you all have done, I have followed with great admiration. And the information that I'm sharing, I think, is the story is not fully cooked. You know, I think there is I have some ideas on how underlying liver disease may influence the risk for DILI, but I think so. I would say this is sort of making a almost like a thesis presentation. I'm open to your input and then what other studies we can collectively do. And by the way, Fernando, Maribel, and Raul, and Anne, you've been fantastic collaborators, you know, over the last 10 years, and I've reached out to each of you, and you've been beyond generous, so thank you for that. And let me just get started. I'm going to share my screen. Is my screen in presentation mode showing up for you, Raul?
Yes, yes.
Okay,
yes.
Let me get started here. These are my consulting agreements, which isn't necessarily relevant here. This is the outline, and I think I'll skip through the background pretty quickly. You know about DILI as well as anyone else. They'll share with you some of our data about drug disposition and NASH and cirrhosis. some discussion about is NASH or MASH a risk factor for DILI? Is DILI worse in people with chronic liver disease and cirrhosis? Collectively, I think your cohorts and our papers, and I think we answered that question, and a few other interesting topics for discussion. You know this, DILI is a big deal. I was just asked by a company yesterday called BioAge to help them because they have a very novel compound. It's an apelin-1 inhibitor for build muscle when patients get these GLP-1 inhibitors. And it's a 200 patient trial, and 6 patients in this had ALT 10 times upper limit of normal. So they stopped the program. The stuff I'm saying is in public domain. This is brand new. It's not uncommon for me to hear a story like this where industry runs into DILI. Either the program has been stopped or has been significantly modified on a weekly basis, actually, and especially oral GLP-1s seem to be a better toxic. So I think this is not going to go away, especially with the cancer therapeutics, immune checkpoint inhibitors. Now we have gene therapy. The more we dive in, I think we will help the field, just not our own field, just the pharmaceutical development of new therapies. I think you all know there are 2 types of direct and idiosyncratic, although I am conceptualizing in my mind, and I think the metabolic idiosyncrasy, I think, is a continuum with direct hepatotoxicity. Where there are idiosyncratic DILI that is dose dependent, that almost behaves. Still, I think it is not entire. There is some idiosyncratic because not everybody gets it, but you sort of know this direct and this idiosyncratic description. And the discussion we will be having is about idiosyncratic DILI. The notion is unexpected, rare, generally not dose related. This is an area that I think we've made some contributions. The prototypes are isoniazid and diclofenac and so forth. I think all idiosyncratic DILI has some immune basis for it, but in my mind, I sort of see is the immune mechanism, is it front end or back end? So for example, there are compounds like some fluoxetines are compounds that give immunoallergic features. And I think the immune mechanisms, I sort of see more front end, they lead, whereas, more the metabolic, for example, isoniazid, the immune mechanisms leading to cell injury, necrosis may be downstream. That is not the sort of the inciting event. And there are still no good animal models. And when I started this field 25 years ago, there wasn't a good model. I think there was Phil Roth at the time was studying LPS primed model, mouse models. I don't think things worked out. And I think Lilly Dara has a model for some compounds, but I don't think there have been reproducible models that we could universally use. Although I think now we are having model systems, right? Whether it is Emulate, Liver on Chip, or whether it is Bob Fontana and Johnny Sexton's human liver organoid. Some of those are, interesting. We may not have an animal model, but we may come up with in vitro model systems that may serve us in cracking why idiosyncratic hepatotoxicity happens for some compounds. Just the point here, if there are clinicians here, DILI can present as just about any type of liver disease. It can be, majority though are biochemical elevations, but it could be severe hepatic necrosis, cirrhosis, NASH, NRH, sinusoidal obstruction, just all kinds of presentations. So if you are a clinician, if you are seeing a newly diagnosed liver disease, and I think it's super important to keep DILI in your differential diagnosis, even like we have seen drug-induced Budd-Chiari syndrome type presentation as well. So I think that's a point that you must keep in mind. I think you all know cholestatic and hepatocellular. This is proving to be an important way to categorize DILI. The notion is hepatocellular DILI is the one that leads to organ liver failure, needing a liver transplant. Whereas cholestatic generally is more forgiving. People don't die as much from liver failure, although I think there are a couple points here. One, this distinction helps you with the signature, right? For example, amoxicillin clavulanic acid presents with cholestatic. Isoniazid is hepatocellular. The signature helps in causality adjudication, but also would help you with prognosis as well. So cholestatic DILI, overall mortality is the same as hepatocellular, but the majority of deaths come from non-hepatic sources. And I think we're going to be doing some work, hopefully, with your consortia, trying to tease out. I think we talked about this and at the ASLD, Raul and Fernando, how we could, because I think there is need to better prognosticate cholestatic liver injury. I think cholestatic liver injury, I have some slides to show, becomes particularly important if you have underlying liver disease. I think you all know Hy's law is highly utilized by the pharma, and I think there are revisions to it. Some of the important contributions have come from the Spanish registry. And the temple corollary is basically an imbalance in ALT 3 times upper limit of normal. And the bottom one is interesting. ALT 10 times upper limit of normal. John Sr., who's passed away during the pandemic, is never written about it, but he had said in the meetings that if there is in clinical trial, if there is incidence of 10 times upper limit of normal, even with normal bilirubin, that means something. He said for every 10 cases of these 10 times upper limit of normal, there would be 1 case of Hy's law, is how he said, about 10% risk. And Raul, as obviously your group, and Dylan, we put the abstract together. Turns out if ALT more than 10 times upper limit of normal, even if the bilirubin is completely normal, the incidence of Hy's law is turning out to be about 24–25%. Of course, we have to we have to play with the Hy's law definition, but I think we are validating what John Senior has said. So this is an important point to highlight as you are advising pharmaceutical companies in terms of DILI risk for their compounds. This is E-Dish, brilliant contribution from Dr. John Senior, shows on x-axis is peak ALT times upper limit of normal, and y-axis is peak total bilirubin, times upper limit of normal, and you sort of see the Hy's law. I think you all know, seen this. And there are studies are ongoing to modify E-Dish, and I think I have a couple slides. And also there is a cholestatic E-Dish that's people are starting to think how to plot. And I think some of the work we will do this year, the coming year, I think we will give a crack at that. There are a few slides that I'd like to share with you. These are courtesy from Dr. Skip Hayashi from the FDA. This is important though. If you're doing a study, a trial in patients with underlying liver disease, where baseline liver tests are already high, E-Dish isn't really a good way. If somebody is starting with jaundice, how are you going to do Hy's law? So these are the Sankey plots. This is a good way to see what's happening. In the middle is baseline and what happened to people. This is sort of a visual between intervention versus placebo to see just the overall trends. Are we seeing moving patients from more patients from Temple? Are they going into Hy's law? Also, this sort of helps in terms of therapeutic efficacy as well. If fewer patients are in Hy's law or Frank jaundice, and I think it just sort of gives a flavor. And I have not applied this yet in the DSMBs that I have done, but conceptually this makes a lot of sense. The next is composite plotting. This is a new paper that I'm still digesting. This is from the FDA. This test fall data is just come on drug safety. Bottom line, though, is there are three parts to this composite plotting. So one is, first you look at first you plot E-dish using upper limits of normal, the classic E-dish. I think this is automatically moving. And then the second you see is on treatment, what happened to them. And then the third is sort of you do this composite matching. And still I'm sort of looking for some examples how this helped. But I think more to come on this, but this is exciting development in 2024. And this is another way modified water plot. This is once again in people with underlying liver disease, basically seeing what happened to ALT between, you could see both groups had a sizable number of people with elevated ALT at baseline and what happened to them. You could see in this particular, a drug led to more peaks. This also a visual to see that there's a problem. The FDA, what it does is first it has a visual, then it zeroes in onto these spikes so they can better study. So the composite plotting is a new development. The Sankey plots and these modified water plots all have come in 2024. Really courtesy Dr. Hayashi, who's a noted hepatologist in the Dillon, moved to the FDA, and I think is making important contributions. This is the water plot. So just moving on to these sort of the next part of my talk. Very early on, I was interested. Craig Lammert is a colleague at IU. Craig at the time was a medical student. Now he's a star faculty doing really funded research in different areas. At the time, we wanted to test if there's a relationship between the dose you take by mouth and the risk for DILI. We use publicly available databases. And this is, once again, pharmacoepidemiology. We saw a signal that if a compound is given at less than 10 milligrams per day, the risk of jaundice, death, et cetera, is significantly lower. Back then, we did not see any active medications given at 10 milligrams or lower was associated with needing a liver transplant. At the time we published the paper in the UNOS database, that's our transplant, hundreds of thousands of patients. There was only one case of servistatin needing a liver transplant. When we looked at the case, there was just a rhabdomyolysis and just really not a clean case. So this was sort of the first attempt to link dose to DILI. I'll come back to why this is important. Dose becomes important if you're studying DILI in patients with underlying liver disease. Next was this. I think it's the same thing. The next paper, Craig, once again, he is now a resident in Atlanta. He continued to work with us. Here, we just wanted to test. By then, though, people sort of thought, we are now talking 15, 20 years ago, people thought if a medication is hepatically metabolized, you're going to have liver toxicity. No one really tested. Here, Craig tested based on the medications in public domain and their literature. What he had shown is if a compound has extensive hepatic metabolism defined as more than 50% phase 1 oxidation, the risk to have this ALT signal, jaundice, liver failure, liver transplant, fatal DILI, I think there was an important, once again, a pharmacoepidemiological signal. Then he went on to combine these two in the second paper, showed that if the medications that are given at a higher oral dose also happens to be extensively hepatically metabolized, then there is significantly higher risk for liver liability. This is sort of the second paper. Sort of a concept was emerging in my mind that in patients with liver disease, if the exposure is going to be higher, or a liver disease is going to modify drug disposition, that may modify compounds' risk to cause DILI, in my mind. There are other examples in the literature. I think fluconazole is a good example of dose relationship. So patients stably on fluconazole, something happens to them, either they get kidney failure or their dosage is doubled, boom, all of a sudden they get DILI. I think people accept this phenomena with fluconazole. A higher concentration can lead to drug-induced liver injury. And then all of us have seen in our clinical practices, patients are on stable doses of azathioprine, tamoxifen or duloxetine, later to be reported. They're doing well. IBD, 100 milligrams of azathioprine, and then you increase to 150, boom, the DILI comes up. And then a number of examples. In the Dillon, I think we have about 6 or 7 cases of azathioprine where dose escalation precipitated. I think we sort of see the same thing with statins as well sometimes. Some of the work that we have done, I think these are Ming Chen's rule of 2 and rule of 3. Now are used. Basically, rule of 2 is if a compound is given a 100 milligram dose, and then also is sort of log P3, the lipophilicity has significantly higher DILI concern. And then Min-Jun went on to do this rule of 3, basically added reactive metabolites. But generally speaking, the rule of 2 is better accepted because I think there is an overlap between rule of 2 and rule of 3. So I think this sort of validates. Now FDA, when it looks at new drug applications, they do get the rule of 2 into their overall dossier. And once again, going about the exposure, where I'm going with this is underlying liver disease will modify concentration, will modify the exposure of a compound, thus changing the DILI risk. That's sort of my hypothesis at this stage. Whether it affects to only cirrhotics or whether it is related to certain compounds, certain types of liver disease, I think we have to work through. Underlying liver disease concentration may become important. Here is a paper from a slide from Will Proctor, a really brilliant pharmacologist. Was at Genentech, and I can't remember what he is, where he is, shown that compounds with plasma concentrations, Cmax exceeding 1 micromoles, present a risk for DILI, as well as other toxicities as well. So if you are looking at a pharmaceutical compound's risk, I think pay attention to the Cmax more than 1 micromole is a risk factor, okay? And then also, this is sort of the dose. Once again, I'm hitting on this dose. So this is a paper we published now 15 years ago. One of our postdocs was studying salicylate to improve the risk of endothelial function in people with HIV. It's a small study. This was more a mechanistic study, and I think we had 4 or 5 people with DILI from salicylate, and this was all dose. Like everybody was getting the same thing. When we looked at it, this was concentration related. The people who had hepatotoxicity, if you look at their concentration, was significantly higher at week 4, and we could restart salicylate at a lower dose and get by. So this, once again, in our, and I would say this is a bit mixed between idiosyncratic and dose related, and idiosyncratic and direct. And then also this thing about the direct hepatotoxicity, right? You can avoid direct hepatotoxicity by giving lower doses. Here, what seemed like idiosyncratic salicylate, dose related, we could re-challenge at a lower dose. I think so. There is sort of a continuum in my mind, in a not such clear distinction. And there are a number of other examples about this dose, underlying liver disease. This sort of probably the first set of data coming with compounds, direct-acting antiviral agents were looking to be quite hepatotoxic in people with underlying liver disease. And this was related to AUC. For example, Child's A patient with Hep C patients could take Piridoprevir, not have DILI when they're going to Child's B or C. Their exposure was increased almost by 1,000-fold, and the risk for DILI was dramatically increasing. The same thing with Zapatir. And so this is now, we are talking maybe 2014, 2015, theories emerging that exposure concentration is important for certain types of DILI. You don't see this for all, but certain cases, certain causative agents. And if you have advanced liver disease, you're going to modify the exposure, especially if it is starting at a higher dose, and especially if the drug metabolism is impaired in that class for the medication. And the same thing with obeticholic acid, right? Dose related. We've seen with NASH, when you give 25 milligrams hepatotoxic, you can get by with 10 milligrams, but it wasn't effective. And the PBC program had hepatotoxicity in people with cirrhosis, where it was related to concentration alone. Hope I convinced you that many sets of data now show concentration is important for DILI. Idiosyncratic DILI, so-called idiosyncratic DILI, that's sort of merging with the concept of of direct hepatotoxicity. More to come, and I think this is still an evolving story. An area of interest, I sort of, as Dr. Andrade said, I sort of do both NASH as well as DILI. An area of interest has been, how does NASH modify the risk for DILI? And also, my statin work was in people with underlying fatty liver disease. So I think there are many reasons that we can postulate that underlying liver disease, especially NASH, can dramatically change drug metabolizing enzymes and transporters, and you can extrapolate that to somehow setting them up for DILI. And this is not fully fleshed out. And I think more work needs to be done in experimental systems, as well as in more cohort studies, as well as epidemiological work. This is a work Raju Palanchi and we published many years ago, showing steatosis dramatically reduces cytochrome P450-3A activity. Here we actually studied microsomes, hepatic microsomes, as well as 3A activity using the hepatic microsomes from liver samples. As there was more hepatic fat, there was less 3A activity. And I think there are a number of other papers, and this tracks to what folks have seen with diabetes as well as obesity. Going back to 1980s, folks have seen if their obesity and diabetes negatively correlates with 3A activity. Why 3A is important is, 50% of medications, small molecules, are metabolized by 3A. This is really a big pathway. So I think the fatty liver modifying 3A, and if it is not metabolized, your concentrations are going to be higher. So that's the point here. And this is a work that we have done in sort of an RNA-seq, bulk RNA-seq, and also a meta-analysis from published RNA-seq work from NASH samples. I'll just quickly show, I'm not going to have time. MASLD activity score significantly modified the pharmacogene expression. And the same thing with fibrosis, dramatically changed. And these are the genes that are dramatically, their expression changed with the tracks with advanced fibrosis. This is going to have some implications in terms of their PK/PD. And one thing we zeroed in on is cytochrome P450 2C19. This is clopidogrel. This is a meta-analysis, including our paper, showing that NASH in NASH compared to either controls or fatty liver, there was a significant reduction in a consistent fashion. Just about all these papers, almost a dozen papers, and the same thing with fibrosis. Actually, more effect with fibrosis as well. Bottom line, I think this is a clear depiction that in a meta-analysis, now you can show that gene expression for important cytochrome P450 drug metabolizing enzymes is dysregulated. In cirrhosis, the farm PK is significantly disturbed, and many reasons. Decreased blood flow, shunting, and so on and so forth. I'd like to make 2 points, though. One is, generally speaking, the drug disposition in Child's A, especially A5, is relatively preserved to people with just a chronic liver disease without cirrhosis. So the changes you see in cirrhosis start at A6 when there is portal hypertension. Child's class B, you clearly see for many compounds starting to have higher AUC accumulation. So that's one. Second point I'd like to make is the shunting, especially intrahepatic shunting. You don't really see until Child's class A6, meaning, so A minus. So, and the intrahepatic shunting, really you don't see until you have thick septa. It's been an interest to me to see if somebody with bridging fibrosis, would they have intrahepatic shunting that would modify exposure, but that's not the case. So it's Child's B that's when sort of shunting and drug disposition is dysregulated. There are just a number of ways that the pharma predicts idiosyncratic DILI. All these, there are, for each of them, for every paper that said it has a good predictive value, there's a paper or 2 papers saying it isn't good. So preclinically, by pharma, as they are identifying compounds to take them to market or to further testing, it is more art than science. And I think we're making progress, but nonetheless, and I think there is that's why these things come into, that's why we're still seeing compounds in phase 2, phase 3 testing. Another point I'd like to make, though, is all these assays and studies are geared for people without liver disease. I've been advocating for industry to start build their steatotic hepatocytes, or if they have a model system, organoid fatty hepatocytes, or culture them with palmitic acid. Otherwise, industry isn't doing a good job in terms of pre-screening higher potential for toxicity in fatty liver. Okay. So underlying chronic liver disease and DILI. Some of the things, the main thing is, are individuals with chronic liver disease more susceptible to idiosyncratic DILI? The second, that's open question that I'll discuss. And then the second is DILI associated towards outcomes? I think we answered that. Raul, Maribel, your paper and our paper from DILI basically confirmed what's been said in textbooks and their experience, clinical experience. I'm not going to touch on the causality here. If you look at the literature, this is Jim Lewis and Jonathan Stein's excellent review article. What are the drugs in the textbooks or review articles showing increased risk of hepatotoxicity in people with underlying liver disease? This is sort of the stuff. Some of these are being questioned again, even going back to anti-tuberculous. And I think now there are data to say maybe methotrexate doesn't do what we believed it does. So I think this needs to be tamoxifen. I think majority would agree underlying fatty liver disease increases the risk for steatohepatitis. Okay. This is a very classic paper, highly quoted, now almost 25 years old, published in Hepatology, showing that underlying hepatitis B increases the risk for anti-tuberculous treatments. They had 3 groups of people. They had Hep B controls not receiving anti-tuberculous treatment on far right. And then 2 groups of people received anti-TB therapy. A group had Hep B background and others did not. Basically, they said suspected DILI patient with Hep B who also got anti-TB, anti-tuberculous therapy at a significantly higher risk. I think it almost about 4-fold higher. But the problem with this paper, though, DILI was defined as ALT 1.5 times upper limit of normal. So that's a low bar. Another one, though, this is intrigued me. Most episodes of ALT elevation were associated with an increase in HBV DNA, irrespective of E antigen. If I'm looking at this today, I'm not so sure I would call them suspected DILI, just because this could well be flare up. But this became sort of the standard citation to say how underlying Hep B is a risk factor for anti-TB DILI. And the same thing with viral hepatitis and the risk for antiretroviral. A lot written 15, 20 years ago, Hep C was a risk factor, but if you ask folks who spent time like Dr. Sherman and others, Mark Salkowski, most would now say it is immune reconstitution rather than, and the reactivation of viral infection rather than DILI itself. And anyway, new antiretroviral agents are exceptionally safe from a liver standpoint. And there are some drugs that cause underlying liver disease and the chronic DILI, tamoxifen we discussed, the things that are important to remember, irinotecan and stavudine. If you have underlying fatty liver disease, it may get worse. And there are 2 drugs from Eli Lilly, peglispro, and a novel glucagon receptor antagonist, not agonist, that we are studying for weight loss. These 2 cause drug-induced hepatic steatosis, and interestingly, the risk was associated with the PNPLA3G risk allele. This is a paper that I was alluding to. My first foray into DILI investigations, 2002, 2003. Basically, what we have shown in this gastro paper, now 20 years old, is if you get put on a statin, your liver enzymes will go up. But if you have, and if you're starting with high ALT, get put on a statin, your liver enzymes will go up. But similar patients who have high ALT who don't get put on a statin will have sort of the same fluctuations. So this is not from statin, but rather background fatty liver disease. I think we're sort of our conclusion in this paper. This paper was followed by probably a dozen other studies saying the same thing. And then also this sort of an important paradigm to how to test, the risk for DILI in people with underlying liver disease. We sort of model the same thing for rosiglitazone, and a few others have done. But the statins in people with underlying liver disease do not carry excessive DILI risk. I think that's fair. This is a paper that Craig Lambert, once again, and I published using our statewide epidemiological data. We built a chronic liver disease group and coupled control groups. And what we have shown, though, this is interesting. Our hypothesis was individuals with chronic liver disease are not at risk for DILI due to common hepatotoxic agents. We sort of looked at top 10 prescription medications in the Dillon papers, and we put them all together. And what we have shown is, and let me just walk you through. So the middle column is chronic liver disease, and they were exposed to 1 of 10 compounds, and their risk for suspected DILI was 2.1%, okay? And whereas control group 1 and control group 2, these people had normal liver enzymes, and some had the Prati criteria really low. And their risk of DILI, suspected DILI from those 10, one of those 10 agents was 0.4. So this was significantly higher. So our null hypothesis was proven, was rejected. So the odds ratio was about 5 to 6. Then also the interesting supporting evidence is risk of death was significantly higher in this group, further sort of supporting what we are trying to show in this research letter published in Clinical Gastro and Hepatology. I suspect some of you reviewed this paper. Interestingly, though, subsequent to our paper, there was another research letter published in Clinical Gastro and Hepatology, South Korean population-based study, sort of odd statistical work, nonetheless making a case that if you have NAFLD diagnosis, risk of DILI is higher. I think its IRR is about 7.7. If you look at an old Italian prospective study, they also, now we are talking close to 20 plus years, also showed NAFLD was significantly associated with DILI odds ratio of 3.94. So 3 sets of data, Italian data, our epidemiological data, then the South Koreans saying NAFLD may have sort of a all-cause DILI, although not statins, because we disproved, I think, in my mind, the statin risk and a number of other papers. So interesting, this needs to be followed up. At the best, I would describe this as a pharmacoepidemiological suggestion, a signal rather than a hard fact. I mean, how NAFLD, NASH, or MASLD, MASH might increase susceptibility to DILI, number of reasons. I mean, increased reactive oxygen species, there is increased endotoxin, ER stress, mitochondrial dysfunction, transporters, now we are now believing the BSEP really plays an important role in causing DILI. If a drug has profound inhibition of BSEP, and I think pharmaceutical industry is not really moving that compound forward. So I think many reasons why this could happen. So sort of the last few slides. This is a paper looking at Marwan Gabriel, who is also at IU, in a paper showed that if you have underlying liver disease, it's a significant independent predictor of 6-month mortality. Odds ratio is about 4.6. This was an important piece of data. Then there are 2 sets of data. The top one is from IU, and the bottom is from Rahul and Maribel, showing if you have underlying liver disease or pre-existing liver disease, the risk of death is significantly higher. Basically, not a surprise It's been written in the textbooks going back to Dr. Hy Zimmerman in the 80s, but documenting this is important, adds to growing literature about DILI in people with underlying liver disease. A couple other interesting things, though, in this space. You know, I touched on early, when you have DILI, hepatocellular DILI is worse from a liver standpoint than cholestatic DILI. That may not be the case if you have underlying liver disease. You know, here cholestatic DILI is equally bad as hepatocellular DILI in patients with chronic liver disease. Now, FDA sort of agrees to this notion. This is from Dylan data. I've been wanting to work with Spanish registry to reproduce this. What you see is if you have hepatocellular DILI or cholestatic DILI in people with underlying liver disease, all-cause mortality is the same, liver-related deaths are the same. Our chronic DILI may, of course, it's higher. So the point is the benefits of cholestatic DILI in people without liver disease no longer persist if you have underlying liver disease. Cholestatic liver disease is equally bad. And there's this thing that's been interesting to me. Can a compound be hepatotoxic for one type of liver disease, but not another type of liver disease? This is fascinating. The Dr. Hoofnagel thinks methotrexate may have exhibited similar phenomena, but I can't find anything published in the literature. Saroglitazar is a PPAR alpha gamma agonist. This is approved in India to treat NASH and to treat dyslipidemia. It's been given to millions of people, no DILI. But when we did a trial for this compound with PBC, we had 3 out of 13 patients had significant DILI. And so this is in PBC. The first instance in my experience where a compound proved to be safe in one disease, but hepatotoxic in another. And because of and also this was a dose relation, by the way. The 4 milligram is where we saw most cases, 2 milligrams we saw 1. And we moved this program to phase 3 where 1 milligram is being tested. We have not seen any DILI. So interesting. The type of liver disease may have bearing in the risk for DILI for some compounds. And this was published in JHEP a couple of years ago. Raj was the first author in this paper. These are just the line graphs of AST, ALT, bilirubin, alk-phos, and bilirubin from that paper. I think just sort of really sort of conclude my talk. I think underlying liver disease is turning out to be important, especially advanced stages. In addition to defining outcomes, I think there is risk for certain compounds, certain stage of liver disease, and certain types of compounds. Whether the compound, in my mind, compounds given at a higher doses, and then that are hepatically metabolized, more likely to have exposures that may end up being toxic. And then I'm still trying to work through how the shunting, if you're shunting, you actually may be lowering exposure, hepatocyte exposure. How does that work into this? And I don't have a good theory. So that's what I have to share with you is, underlying liver disease. When I started, people sort of discarded, liver disease is not a risk factor. Once you have it, the outcomes are poor too. I think this concentration, drug metabolizing enzymes, drug-drug interactions, the stage of liver disease, type of liver disease. So this is work in progress, not a complete story, but that's what I have to share with you. And I truly appreciate the opportunity to make this presentation. And I think we have time, maybe 10 minutes for Q&A or longer. I'm going to stop sharing.
Okay. Thank you very much, Naga, for this really wide-ranging talk. It's absolutely fascinating. And it certainly looks like answers are still not entirely comprehensive, but that there are some important individual cases where DILI is definitely more common in liver disease, especially advanced liver disease. We need to ask the audience if they have any questions. The best way to do this is to use the tools on Zoom.
Yes. Can I ask a question?
Yes, of course, Rahul, please.
Yes, congratulations for this very nice talk, Naga. Yes, because for me, it's some kind of eternal question. It's because you show in your pharmacoepidemiological approach that NAFLD, now called MASLD, will be a risk factor, a general risk factor for DILI, because you implicated in your study most common hepatotoxic drug in US, no? But this is something that is not clearly identified in prospective registries. We failed to demonstrate clearly that, for example, MASLD or even the components of MASLD, obesity, or type 2 diabetes mellitus, or maybe really a general risk factor for the general incidence of DILI with several distinct drugs. My thinking is that probably something that could happen is that causality assessment, these cases that with confounding factors probably are not so clear, and probably there is some bias, some selection bias in prospective registry, and that may account for a lesser inclusion of these cases. So what do you think? It's because it's really strange that we fail to find in general that MASLD or some of the components of MASLD are risk factor for DILI, for idiosyncratic DILI.
Yeah. Fernando, although I published that paper, we also have published that data that just don't reconcile with that. For example, the statin one, that really is not the case. The other one that's not well publicized and the group is, we did not find the NAFLD risk alleles enriched in the DILI studies, right? I was just, if this is the case, if NAFLD is a risk factor, I just hope to see, G allele overrepresentation of PNPLA3. We did not see that. So yeah. I think, 3 small studies, epidemiological studies say it, but until 10 other studies sort of say the same thing, or a nicely, rigorously done disputes it, I would just say it's up there. This is an interesting observation that requires further follow-up, because I think it has important implications, right? So I think I've been thinking, a couple things. In the DILIN, we have baseline VCTE on all. So we can look at the baseline CAP score, and once again, just the DILI severity. We cannot assess the risk of DILI. That's the problem. So I'd be happy to brainstorm with you to see how we can further address this. But I think it's, I would say, provocative observation or a postulation here.
I have a question.
Yeah, please go ahead.
Hi, Yang. I'm Fernando.
Hi, Fernando.
Hi, very nice talk, Naga. I've a clinical challenge in daily practice is regarding methotrexate, indicated in a fatty liver. What is your thought regarding methotrexate in a fatty liver with normal transaminases? This is a very challenging situation in clinical practice.
I've been following, I would say, maybe about a dozen fatty liver patients for over 20 years who received grams and grams of methotrexate for rheumatoid arthritis or psoriasis. I've not seen their fibrosis progress, biopsied them multiple times. So if you have a fibroscan, and if they're not drinking alcohol or don't have hep C, I am of the view that methotrexate poses very minimal risk of fibrosis progression. I don't know what others think.
Yeah, I think so. Thank you.
Yeah. Could I ask a question, Naga, about your data on drug metabolism in MASLD? The finding about 2C19 going down is very, very interesting, I think. And we've been able to confirm this using proteomics, and the fact also that it seems to go down relatively early in the progression of MASLD. Now, this has nothing directly to do with DILI, but it raises the question of whether many of these patients who need to be on clopidogrel should be given a different drug. What's your view about this? And is it something that could be as important as their metabolizer status, whether they have MASLD or not?
Yeah, totally. And I think we had plans and to bring patients with MASLD to do detailed PK and also functional assays, except the grant was not funded. And the first author of that paper, Nick Powell, decided to leave the US and go to South France and had a change of careers. So, but I think this needs to be followed up. I think he's a smarter guy than the rest of us, I think. Now, totally needs to be followed up, and I think has vast implications. And there are a number of other things too. 3A part, I don't think it's been studied well, as there is about. If you look at Raj's original paper, when we looked at 3A activity itself, we also have done midazolam in cocktails, the same thing. I think there's about a 60 to 70% reduction of 3A activity, although some of there is redundancy, other CYPs pick up. I don't have a good theory for that to do hepatotoxicity unless the metabolite is hepatotoxic. Excuse me, the parent drug is hepatotoxic, not necessarily the metabolite.
It's pretty unusual for clopidogrel to be a causal drug for DILI anyway.
Totally.
You would agree with that, but it is really a very commonly prescribed drug. Certainly in Europe, I don't know whether some of the newer drugs are used more widely in the US, but certainly in Europe, a lot of patients are on clopidogrel and may not be benefiting from it if they have MASLD.
Yeah. I think that needs to be followed up. I'm just saying, though, is 3A part. If you have a parent drug, and if it is not metabolized well, and the parent drug rather than the metabolite is hepatotoxic, arguably, fatty liver could increase. That one, and then I've not touched on, and some of these efflux and influx transporters are also profoundly dysregulated in MASLD. Hard to study. Kim Brower from UNC studies that, and I think that also plays into this as well. But if there is one point I'd like to take home, one message is concentration is important. We did not think that 20 years ago when we were thinking about DILI. And then the concentration is one that is modified in underlying liver disease, various stages, various types of liver disease. So that's sort of the final message.
Maribel
Yeah.
has a question.
Well, congratulations, Naga, for this very inspiring conference, because indeed has brought me quite ideas. No, I would like to share with you some. You know, we have a very nice case, a very well documented case of a patient, very old patient, by the way, who was on statins, 40 milligrams, and then she was turned into 80 milligrams and developed drug-induced liver injury. So this is clearly what you are saying, and what you have just said, that is very interesting and very important to not only drug dose, but exposure, hepatocyte exposure to a drug concentration, what the exposure in the body. So that's very interesting. And at the same time, another case, another statin case in another person, when the drug was reduced, the person was able to be re-exposed to a lower dose without developing DILI. So that's reaffirms in some way and confirms what you are talking about. That's very interesting. And I would like to, because we are talking about obesity or higher drug exposure, but what about lean body weights? People that are very slim, or for example, older age, they reduced body weight, if they are given the same dose, for example, in a clinical trial, the same dose as the one that a person with a higher body weight, or even this was the case of a female. For a male, given the same standard dose to a female lean body weight, she is going to be over prescribed, no? So the concentration she's receiving is very much higher than for the standard dose in a normal weight man. So
Now, Maribel, you make a really good point. I haven't thought about it. You know, how the volume of distribution
yes,
for these drugs in PK plays into it. You almost wonder, you know, just the sort of the slightly higher risk for DILI in women in the registries and so forth is somehow related to, you know, higher exposures.
yeah,
You sort of say polypharmacy, but that, yeah, that's a really good point. I haven't thought about it, but you know, to most part, we don't separate the doses between men and women, but the, you know, volume of distribution clearly is separate. That's a good point. We should follow up on.
Particularly if they are with low body weight, very lean women. So that's, that will be a good point, very nice point to look after it.
I would say though, recently a colleague from Philadelphia reached out to me. He had a patient with this Mycobacterium avium intracellular, needed azithromycin, long-term azithromycin, had DILI. And he really had no other options to do. And restarted a low dose, honestly, gradually increase over the course of 2 months. She's been able to tolerate it, almost like, you know, inducing. This was a classic DILI. And I think we need to continue, you know, what kinds of drugs, you know, that's the, no, you don't want to do if somebody has hypersensitivity type, somebody who has DRESS syndrome, I think that would be a mistake. I think carefully we could do re-challenge, even for non-cancer drugs, you know, somehow induce, whether they need immunosuppression. I think exciting areas to, you know, this dose related, but
yes.
Yeah.
We'll look at it. We'll look at it.
A final question for me, Naga. It really concerns possibly what Maribel's already been talking about. In flucloxacillin DILI, which I know you don't have in the USA, there really is an age effect, and particularly in women over 70. And to me, this raises a question as to whether some of what you've been talking about in relation to MASLs and other liver diseases, whether there are three factors at play here: the liver disease, the age of the patient, and the drug they're being given that could cause DILI. Do you have any data on that?
No, I mean, I could see, I mean, age is a risk factor for many compounds, right? For example, amoxicillin clavulanic acid, dramatically increased risk. I don't think I have thought too much about why that is. I mean, it can't necessarily be immune system. It is, if anything, there is, lower immune response in the elderly. And I don't necessarily think that it's the drugs they are on. I think it has to be something happen either to their liver, the concentrations. I think that's a good point. And it can't really be the genetic architecture, right? Their HLA doesn't change.
No,
right?
no, the HLA should be the same.
Yeah.
I think it might be concentration, but I don't know for sure.
I think this is interesting. I haven't thought too much about that particular drug in age or, for example, lean body mass part. But I think, these seminars give ideas, and I think that's one I'll take back. Okay, wonderful.
So
another point that I think is very interesting is his law definition, or his law. We have seen and we know that not his law that is different according to the drug. So not all drugs meet criteria for Hy's law. So patients with underlying liver disease, what about the Hy's law definition? Maybe it won't be the same. That patients who do not have an underlying liver disease.
Yeah, I think, Maribel, I think we need a new way to risk stratify people with underlying liver disease. The E-DISH and the Hy's law was just for general population. In people with underlying liver disease, especially with advanced liver disease like alcoholic liver disease and so forth, we have to come up with different framework. Just sort of, tweaking is not, but yeah, you're right. For example, diclofenac or minocycline Hy's law virtually has 0% mortality, so are very minimal. So I think Hy's law is not created equal. Hy's law from isoniazid means very different than Hy's law from, for example, from diclofenac. And then also, I think we just need a different law for people with underlying liver disease. I don't think we can apply Hy's law. Okay. All right.
I'm not sure how we're doing for time, or whether anyone else has any additional comments. Raul, Maribel?
Bernard, I think.
Yes.
Oh, Bernard
Yes. Yeah, thank you. A very, very interesting talk. We are working on in vitro model of NAFLD, and if I understood well, you advocate for the use of cellular models of MASLD in preclinical studies to determine whether or not a drug can be more toxic or not in the context of DILI. In the context of MASLD, sorry. But I would like to underline that not all models of MASLD are equal. And people just sometimes stop only on the stage of steatosis. They are very happy because they are steatosis in their cells. But they have to do more and to see whether the main cytochrome P450 that are modulated in MASLD are also modulated in their model, and many people working on this model do not report the variation of CYP2E1, CYP3A4, CYP2C19, etc., etc. And I think for the audience, it is very important to stress that this is important to know the real value of the model. And just now my question to you. So, I mean, phase 2 and 3 are done on normal subject. Do you know that it is a possibility that in the future, this trial will be done on obese people with NAFLD?
I understood your comments, and I'll come to that, but I don't think I quite caught the question.
Yes, I wonder, I mean, the phase 2 and phase 3 are done on normal subjects.
Yeah.
But I wonder whether in the future, given the importance of MASLD in the general population, do you think that this population will be considered in the trial? In this phase? Sorry.
You know, I really important thoughts though is I'm not so sure I'm advocating for in vitro toxicology testing in a fatty liver model for all compounds, but if your compound is being developed for liver disease, okay, or if it is going to be in populations like diabetes, obesity, dyslipidemia, where there is background fatty liver disease, I think it's really important to actually your model system not just get primary hepatocytes, not know their fatty status or their PNPLA3, but I think be cognizant whether you create steatotic hepatocytes or whether your model system in vivo in terms of the MASLD in phase 2, you know, by the time you come to phase 2, at least in the US, people are not doing healthy volunteers anymore. They're already going into the disease population. Phase 2A, disease population, dose finding, majority will have MASLD. Today, industry uses ALT sort of as a proxy, but we know ALT is really a horrible marker for underlying MASLD. So without their knowledge, I think they're already having, you know, a third of their participants may have underlying MASLD. So, you know, becomes important, you know, yeah, I think, I'm not sure what we're going to recommend. Do we recommend everybody get a FibroScan like they get ALT so they know whether they have baseline MASLD? Maybe if we prove MASLD is a risk factor, but I don't think we are, you know, we are not there yet.
Okay, thanks.
I have one more clinical question. Is possible?
Yes, of course. Quick.
Okay. Okay. Do you think, Naga, that the liver biopsy have a place deciding whether to indicate a particular drug, or is FibroScan sufficient?
I think rare examples I can think of, Fernando, where I might do a liver biopsy. Tamoxifen is one example.
Yeah.
You know, for example, I felt comfortable tamoxifen because, you know, majority are, you know, sort of premenopausal, perimenopausal women. They really don't have high liver stiffness, but they have high CAP. I've been biopsying them to see whether they have significant steatohepatitis or fibrosis in that. That's one instance. And of course, older days before FibroScan, we were doing biopsy for methotrexate, which I no longer do.
Yeah.
I think that's one that comes to mind. Otherwise, I think a good clinical examination on FibroScan would be sufficient, in my opinion.
These are two conflicted drugs, tamoxifen and methotrexate. Exactly. Yeah.
All right.
Okay. Well, I think we've come to the end, and I would like to thank Naga again first, and also to thank the audience for staying with us and for their interest in this seminar.
Thank you. You all have a great Christmas and New Year's. Thank you.
Yes,
Thank you.
happy holidays to everyone.
Yes,
Thank you.
same for you, the same for
Thank
you
you
and
very
your
much,
family.
Naga.
Thank
It
you.
was
Thank you.
fantastic.
Thank you.
Thank you,
Thanks,
Anna.
everyone.
I would like